Okay. And then next is hypertension in pregnancy. Artika, what will you ask if your mother comes at 36 weeks with no previous history of hypertension in the clinic visit at 28 weeks, admitted for confinement?
36 weeks.
Yeah, 36 weeks. He's admitted for confinement, let's say. What would you ask?
I would ask when the blood pressure was detected to be high, if it was at the booking visit or after 20 weeks of POA, at 28 weeks visit, and if she was given aspirin, and how her blood pressure control was throughout, if she was started on any medications, and if it started on any medications in the sense if she had like very high blood pressure and if she was ever admitted to the hospital before. What else to ask? How if she was monitoring her blood pressure at home, if she has any records of her control, and
Very important thing you need to ask. The PET symptoms. Preeclampsia toxin.
yeah, PET symptoms.
Yeah, don't forget that.
Any
And yeah, go on.
PET symptoms such as head to toe, headache, blurring of vision, uh, abdominal pain, nausea, vomiting, like reduced urine output,
Yeah.
and everything needs to be.
Yeah. Complications you can ask. Abruption. She had.
If she had any episode of PV bleeding in the past.
Yeah.
And
And intrauterine growth
during
restriction.
the so during the growth scans and anomaly scans, if any abnormalities were detected, if she was told that her baby was small.
So when there is like a chronic disease, you can like make like 4 columns or 4 boxes and write like in the first thing as symptom analysis. So if she presented hypertension, you can ask if she presented with any symptoms, anything, and then you can put in the other box etiology. So if she was having hypertension during the pregnancy, if it was diagnosed at booking visit or after 20 weeks of POA. And then other thing you can put is the complications. So complications you can write is if she has any preeclampsemic toxic symptoms, and then if there is any problems in the fetus as well as any problems in the placenta. And then the other boxes you can put treatment. So symptom analysis, etiology, complication treatment, then you for not forget like important points. And yeah, then you can ask about the growth scan and any intrauterine growth restriction. What can you ask about in the booking visit? I think
Booking visit, if the blood pressure was normal or not. If the blood pressure was checked and if it was normal, and if we should make sure there were 2 readings taken.
yeah.
So that was that, and
Yeah, and if she was started on aspirin
previous
at 12
history of
weeks,
sorry, previous history of PIH, like
yeah,
PIH in the previous pregnancy.
yeah. So on examination, so yeah, pretty much that's it. And if she was started on aspirin and everything, and then on examination, you can ask about the BMI. Then if she has any pallor, edema, gum bleeding, important to check the blood pressure, reflexes, clonus, vision, and even any creps in the lung bases, right hypochondrial pain, and then check for the LICA in abdominal palpation and the symptoms of under height, and even check for right hypochondrial pain. Investigations is you can do full blood count, liver function test, serum creatinine, UFR, PTINR, urine wart
Urine
test, ultrasound.
protein. Yeah.
Sorry?
Urine protein.
Yeah, urine wart test, ultrasound scan, and even CTG. So when there are like management principles when it comes to hypertension, like assess the mom, control the blood pressure, detect the complications, and then monitor the fetus, and time of delivery and postpartum monitoring, like the things you have to keep in mind when you're managing a mother which who has hypertension. So drugs you can give if it's mild hypertension is like nifedipine, methyl-dopa, labetalol, and the pathology is when the placenta invades. It's invaded by primary and secondary invasion. If there is failed invasion, there is hypoxia of the placenta. This causes tissue necrosis, which is releases factors into the mother's circulation. This material causes increased blood pressure, so there will be increased flow to the placenta. So also there would be these factors that are released during hypoxia cause increased vessel permeability. Hence, you can have leaking of like proteins and all from the kidney, and this can lead to edema. So the how it goes is PIH, pregnancy-induced hypertension, can become into preeclampsia, then preeclampsemic toxemia, and eclampsia. Can you tell me the definition of PIH, pregnancy-induced hypertension?
A previously normotensive patient who was detected to have an elevated blood pressure of more than 140 by 90 after 20 weeks of POA, the blood pressure was checked twice, 2 hours apart, 2 hours apart, 4 hours, 2 hours apart,
Four,
yeah?
four, four.
4 hours apart.
Yeah,
And
good.
which also returns back to normal after 42 days.
42 weeks or 6 weeks?
Days. 36, yeah.
6 weeks, yeah. Nice. And can you tell me the definition of severe preeclampsia?
Severe preeclampsia is when you have a blood pressure uh, above 160 by 110 and along with symptoms of impending eclampsia.
Mhm.
Right?
Yeah.
And
So,
also biochemical and chemical
yeah.
change. Like
So these
biochemical,
are the definitions. What you said, hypertension
yeah,
without
urine protein.
proteinuria. Yeah, for PIH, hypertension without proteinuria after 20 weeks, which is already in 42 days. Preeclampsia is pregnancy with hypertension with significant proteinuria. Dipstick 2 plus or more, or 300 milligrams per liter. And severe preeclampsia is preeclampsia with severe hypertension, that is 160 by 90 with biochemical or hematological symptoms. So when it comes to severe hypertension, I can go to the management. Yeah, so if a patient has severe hypertension, you give 200 milligrams of labetalol orally stat. If that does not work, you can repeat it in 4 hours, or you can give IV labetalol 20 milligrams in 2 minutes, and then you record it after 10 minutes. If the value is still high, you can increase the dosage to 40 milligrams. And if it's still high, you can consider an infusion of labetalol up to 160 milligrams per hour, where you double the dose starting at 40 milligrams per hour, and you can go up to 160 milligrams per hour. Other option is you can also consider hydrazine IV, that is 10 milligrams. You give a bolus, followed by you can give infusion of 1 to 5 milligrams per hour. So the bolus you give 5 milligrams, and then you can repeat boluses after 50 minutes up to a maximum of 20 minutes, and then you can give a bolus of hydrazine 2 milligrams per hour, increasing by 0.5 milligrams as required. And then oral nifedipine also has a place. So yeah, And then mild hypertension. Sometimes you don't need drugs in management of mild hypertension. You can just monitor, but if it's elevated in self-monitoring or in subsequent clinic visits, then you can consider giving oral drugs like methyl dopa and everything. And then you should know the definition of eclampsia, which is development of convulsions during pregnancy or postpartum with preeclampsemic features. So, yeah. So when it comes to magnesium sulfate, does anyone know how to give it?
It should be given as a 4 gram stacked, 4 gram dose over 10 minutes initially, followed by 1 gram per hour,
Yeah,
1 gram hourly infusions thereafter for
yeah,
maintenance.
yeah. You how do you give the 4 grams?
So it should be given as a slow bolus push. So ideally best is through an infusion pump.
Yeah, yeah. And other method is you can so 20 milliliters infusion pump, or you can put it in burette, no? That's the last option, right?
Yeah, yeah. So
And
either
then
syringe pump infusion or a normal drip infusion one, or the
yeah,
burette.
yeah. So yeah, so it says give loading dose of 4 grams IV or 10 minutes, and either you can give it by infusion pump or dilute to 80 milliliters with 0.9 sodium by burette. So those are the two options. And then if there's difficulty in IV access, you can give IM. And the important things to monitor is the urine output, because if there's reduced urine output, that means that is the concentration, it's exceeded renal. So if there is reduced urine output, it will accumulate and cause side effects. That's why you monitor urine output, you monitor reflexes as well as the respiratory rate. You should keep it between 4 to 7 milliequivalents. And anyone knows the antidote?
Calcium gluconate,
Yeah, calcium gluconate.
10%
Yeah.
10 ml over
And
7
if
days.
there's urine output, you can give diuretics. Another important thing is when you have severe hypertension, you should also monitor the fluids. The maximum amount of fluids you can give is 80 milliliters. And yeah, so you can if patient has hypertension, once she stabilized, or even if after she has eclamptic fit, once she stabilized, you can go for normal vaginal delivery. Just because she had eclamptic fit, that is not a contraindication for C-section. But when you're given normal treatment, you should monitor the patient carefully, give good analgesia, and avoid giving augmentin in the third stage of labor. And you continue magnesium sulfate 24 hours since last fit or 24 hours postpartum. And then you review the patient in 6 weeks. Okay. Next one is grand multipara mothers. There's nothing much. They are usually they have had more than 5 children delivered at term. Then is grand multipara. They are more prone to get anemia. All this, they basically more prone to have GDM, anemia, preterm labor, IUGR, and they are more prone to get twin pregnancies. And then they also have higher risk of having cardiac illnesses. And yeah, then small for gestational age. If a mother has small for gestational age, you can ask when she had was detected of having small for gestation age, whether it was by screening, if the fundal height was decreased, and then the possible causes for this small for gestational age, if it's anemia or if she has gestational diabetes or if she has any hematological diseases, and then how often she has been coming for scans. Her blood group again is important, and yeah, then low BMI, cardiac illnesses, those are all causes of small for gestational age. And if she took aspirin and if she took any additional supplements for the anemia. And yeah, then you can ask if she knows what a Doppler scan is, how often she goes to Doppler and the Doppler results, and if the child was given any dexamethasone, if she's going to deliver the child early, because usually they deliver by 37 weeks. Now, if you have a small for gestation age child, because if you prolong it, there's increased risk of intrauterine death. Then on examination, basically deduce symphysis height and check the BMI and if there are any signs of any thyroid enlargement, ankle edema, and cardiac diseases, all that. Investigations, full blood count, liver function test, UFR, and when it comes to small for gestation age, it can be constitutionally small or it can be actual small for gestation age. That if it's severe small for gestation age, that is when the estimated fetal weight is less than the 3rd centile, or usual small for gestation age when it's less than the 10th centile. So how do we differentiate this? If its constitution is small, it will have a linear growth pattern regardless of the child being small. But if it's small for gestation age, there would not be a linear growth. And so when you're checking the small for gestation age, you check via the umbilical artery Doppler and middle cerebral artery Doppler, ductus venosus, and then you can other tests you can do is like the biophysical profile. My cat is screaming. Yeah. So can someone tell me how do you do the Doppler scan? Rivka?
So in the Doppler scan, what you have to do is you have to check the if there is absent flow, reverse flow, or if it is normal flow. So if it's normal flow, we are not worried. Then we can review the mother every 2 weekly. I'm not really sure about that. And if it's normal flow, 2 weekly. If it is absent flow, then we can confirm our diagnosis by doing middle cerebral artery Doppler and see if there is enough cerebral perfusion. If it is preterm, we can go for what do you call that? Ductus venosus Doppler. So that is if there's absent flow. If there is reverse flow, then you have to go for immediate C-section. Is that all?
Yeah, no, basically.
So
So
the screening is done. If the end diastolic flow is normal, it's every fortnightly, right? Every 2 weeks you
yeah,
re-review. If it is reduced, that is,
3
it's not
days.
absent or reversed. If it is reduced, you do it
3
once
days.
weekly.
Once weekly or 3 days? No, 3 days.
Once weekly, and then if it is absent or reversed, every twice a week or something like that is there.
Oh,
Right,
once
for
a
the
day, once a
guideline,
day, once a
something
day.
like that.
Once daily.
Yeah, yeah,
Yeah, it
You're right.
depends
So, and if
also
it
on
is
the what
reduced,
guideline it is.
Twice a week, right? Reverse nang immediate C-section, right?
That
not necessarily. No, it depends on. So it depends on the maturity and the
So
it
reverse
depends
is
on
definitely,
yeah.
reverse is definitely bad, right? Like the blood is coming this way, Nisa. Like I don't
Yeah.
think you have to keep it in vitro. So you talk to the neurologist and deliver.
That depends on the POA also. Like if it's like let's say 29 weeks POA and or 26 weeks POA, if the neonatologist says you can't and you need, if you can prolong the pregnancy, you can do it daily, and you can do another test like a biophysical profile to check the fetal well-being.
Kamishka, what are the things you see in the biophysical profile?
There are 5 things. One is the estimated fetal weight. Other one is amniotic fluid, fetal tone, fetal movement, and fetal breathing.
Basically that BTH, the breathing, tone, and heart.
Yeah, with the estimated fetal weight and amniotic fluid index.
Another thing is Doppler scan a special scan or is it like they routinely do that, right?
Yeah, they usually do the umbilical artery Doppler, but the best test is middle cerebral artery. Yeah,
No,
after
I
32
mean,
weeks.
is there a specific thing to do a Doppler scanner? That's a routine thing they do usually. Deepasa and all this is that one.
No, if you suspect, ne?
No, I mean, is it the same scan or is there a special machine for that?
No,
No, right?
same ultrasound scan. You can
Right.
done the same.
I sent that there's a nice, the RCOG guideline on IUGR. That screening process is what I said. Repeat fortnightly if the
Yeah,
umbilical artery Doppler normal, and if it is absent or reversed end diastolic velocities, then you have to do it weekly. Sorry, you do it daily. You're right. It was daily, no?
yeah.
But if it is just reduced, it is twice weekly. If it is normal, it is every fortnightly, every 2 weeks.
Yeah. There's another one. This fellow has go to the one document I said, the second, third page. That was as the Sri Lankan one. That is the picture. So it doesn't depend. Different people have their own thing, but just remember, like, I sent another picture.
Sorry, what page of this document?
Huh? Third. It's like a flow chart.
So this is also the RCOG doc flow chart only.
Isn't it a bit different?
No, it's the exact. This picture is from the RCOG guideline.
And then I sent another one. Diagnosis of IUGR at more than 32 weeks, then you do umbilical artery Doppler. If it's reversed, you deliver like what Rifkan said. Is absent also, if it's more than 33 weeks, you deliver. Otherwise, you do daily test. And then if it's oligohydramnios, also you deliver. And then yeah, BPP is the full biophysical profile. So basically, simply, if you suspect IUGR, you do the umbilical artery Doppler every 2 weekly. If it's reduced,
Sorry.
or if it's absent, you do it 3 days or 1 weekly. And if it's no, if it's reduced, you do it 3 days or 1 weekly. And if it's absent or reversed, you do it daily, or you immediately deliver if it's more than 33 weeks or 34 weeks. And then if you are, let's say, below 34 weeks and there is absent or reversed end diastolic reverse flow in the umbilical artery Doppler, then you can also do MCA, which is more accurate in detecting fetal growth restriction. If that is also abnormal, then you can consider early delivery. Otherwise, you can continue the delivery. But then if the mother is less than 32 weeks, if the umbilical artery is
Sorry,
abnormal,
the
you can
cerebral
do
artery is not used to detect fetal growth restriction. That is used to detect fetal hypoxia.
fetal
So if
hypoxia.
umbilical artery is the thing that is used for growth restriction, if your values are absent or reversed and you want to see you to time your delivery, you'd use the middle cerebral artery values.
Yeah, if it's less than 34.
If it's
And
more
then
than 34, no, if it's less than
more
34,
than
you
34,
use
you
ductus
straight away deliver.
venosus.
You don't have to wait. You don't have to worry about it.
Yeah, if it's if it's absent. The problem is if it's before. No?
And then if it's very early, then you have to do a ductus venosus if the umbilical artery is abnormal, because ductus venosus is accurate in the early periods of the pregnancy before 32 weeks. And if you want to prolong it a bit more, if the umbilical artery is abnormal, like let's say in 26 weeks, you can do a ductus venosus and a biophysical profile and try to prolong the pregnancy, and then with neonatal opinion, you can deliver.
Right.
Another
Also,
problem.
the other thing is in if it is not absent or reversed, if it's just reduced the umbilical artery Doppler values, saying doing it twice weekly, or you're saying to do it every 3 days, right?
If it's reduced 3 days.
If it's reduced every day, it's the same. So then to say 2 weekly, no? The guideline says to do it twice weekly, is roughly every 3 days. Then
Yeah. So yeah.
so
And,
same. I mean,
yeah.
keep following that.
Yeah, and then other main reason for this small for gestational age is wrong dates, and then it can be actually small for gestational age, oligohydramnios, transverse lie, and the head can be engaged, or it can even be IUD. And yeah, and if it's due to oligohydramnios, you can check the amniotic fluid index. Amniotic fluid index, if it's between 5 to 25 is normal. If it's less than 5, it's considered oligohydramnios. Or the deep portical pocket, if the deep portical pocket less than 2 centimeters, that is also a sign of oligohydramnios. So,
Obviously, is it 5 or 7?
hmm?
Isn't it 7?
I think 7 is mild and severe is less than 5.
To call it normal should be more than 7, right? 7 or 8,
Normal
I'm not
value,
sure. One of us said 7 or 8, and he was like, check it out.
what does Deepa say? There is no guideline on, like a proper guideline, that's the thing. Anyone has Deepa's book to check?
Yeah, checking. Give us a second.
Yeah, until he checks, there are risk factors for developing, having a small for gestational age child. Major risk factors are smoking, age above 40, if the mother has hypertension, diabetes, or antiphospholipid syndrome. Minor is age above 35, a low BMI, or less than 20, or the pregnancy interval is less than 6 months, or more than 60 months. That is a minor risk factor. Then increase the dates. It's the next topic. So increased date can be due to twin pregnancies. So if it's a twin pregnancy, you have to ask if they had a history of subfertility, if they had ovulation induction, and why were they admitted for? Was it due to C-section, or if they came for any problems in the twins? Example, if one twin had reduced growth, so it can be due to something like twin-to-twin transfusion syndrome. And then how often the scans are. Other option is so if it's increased fundus, important thing is in booking visit, you can ask if she had a fibroid or twin pregnancy, or if she has any diabetes or anything, because if it's a diabetes, she can have polyhydramnios. If it's a twin pregnancy, then obviously she would have increased symphysis height, and then if she has a fibroid also, the symphysis height would increase.
Wrong dates.
Yeah, and then wrong dates. Yes, you can ask in the periods if they are regular or not. And in the ultrasound, the number of fetus, the estimated fetal weight, the placenta, and the presentation of the first twin. Then twin pregnancy, other things you can ask is if the family history of twin pregnancies, if they had an ovulation induction for subfertility, and if they are multiparous mothers. Complications is miscarriage, hyperemesis, antepartum hemorrhage, gestation diabetes mellitus, anemia, intrauterine death, conjoined twin, malposition, postpartum hemorrhage. There's so many risks. Just go through it. So in the booking visit, how to determine the chorionicity is by the lambda sign. For dichorionic is the lambda sign, and for the T sign is there for monochorionic placenta. And twin-to-twin transfusion syndrome is when there is monochorionic twins. And basically there is both superficial and deep vessels in a placenta. If the superficial vessels are bidirectional while the deep is unidirectional. So if the superficial is blocked, there can be transfusion from one twin to another. And then determine the chorionicity and amnioticity. If it's monochorionic, monoamniotic, you do serial scans from 16 weeks every 2 weekly. If it's dichorionic, diamniotic, you do serial scans every 20 weeks, from 20 weeks every 2 weekly. And you give dexamethasone prophylaxis at 32 weeks due to risk of preterm labor. The reason they're probably prone to preterm labor is because there is overdistension of the uterus, so there's more likely to release prostaglandins and cause preterm labor. And when you're delivering twins, if you have monoamniotic twin, you deliver at 32 weeks. Because if you prolong it, there's increased risk of cord entanglement, which can cause hypoxia for both the fetuses. Dichorionic diamnetic you can do at 37, monochorionic diamnetic at 36, and triplets at 35 weeks. Motor delivery depends on the obstetric indication, and lower segment cesarean section done if it's monochorionic, if the first twin is in breech, if there's any growth discordances, and availability for facilities in and usually done in a tertiary care center. If it's a normal vaginal delivery, the key things that to go through is just quickly go through the notes, monitor the fetal heart sounds of both fetuses, inform the consultant, neonatologist, SHO, midwife, and when crowning, you put in the lithotomy position. Once first twin is delivered, you clamp the placenta, if monochorionic, and then you deliver the next twin within 30 minutes. Wait 5 minutes until the contractions appear when you're delivering the second twin. Don't do ARM and determine the position of the second twin. If the position is like in transfers or something, you can do a ECV or internal podalic version. Or if it's in breech, you can even consider breech extraction. Then third stage is managed actively, and post-op you manage with the twin-to-twin transfusion. Post-op you manage with the Meows chart. Then the complication you can get is this twin-to-twin transfusion syndrome. Sometimes they can ask about the twin-to-twin transfusion syndrome severity. There's staging known as the quintet staging. There is 5 stages. First stage is there is amniotic fluid abnormalities, and fifth stage is there is dead baby. Other stage 2 is when there is absent bladder in one fetus, and stage 3 is when there is a Doppler abnormality, and stage 4 is when there is hydrops fetalis of one child. Signs of this twin-to-twin transfusion syndrome is decreased amniotic fluid index, discordant growth, and if there is quintero stage 2 and 3, you can conservatively manage. Stage 3, you can do this laser ablation of the anastomotic vessels in the placenta. After 28 weeks, then you can deliver the baby. Other options is if there is any polyhydramniosis in one twin, you can do amniotic fluid drainage. Then you can remove the septum so fluid goes from one sac to the other sac of the baby. Or last option is there is also you can do selective feticide where you kill one baby. If intrauterine death, you can continue the pregnancy, and you can do MRI after 2 to 4 weeks and monitor with a medial cerebral artery Doppler for the other twin. Then polyhydramniosis causes, that is also another cause of increased fundus, can be due to esophageal atresia, congenital anomalies. So complications is it can cause PPROM, premature rupture of membrane or preterm labor, or and placental abruption, uterine rupture. Investigations, you can do ultrasound scan, amniotic fluid index, and find other underlying cause like diabetes and do anomaly scan. If less than 37 weeks, you can use dexamethasone, 12 mg 12 hourly, exclude cord prolapse and manage conservatively, delivery if needed. And after 37 weeks, depending on the lion engagement, you can do normal vaginal delivery at a tertiary care center. And when you're doing delivery, post-op, manage with the Meows chart. And a few things about fibroid. It can be diagnosed usually before pregnancy or during pregnancy. If they have red degeneration, they can have acute onset pain, dry mouth, malaise, and even constipation. Management is conservative, and you can even give oral ampicillin for 1 week. Management depends on the location and size of fibroid. So like we said before, if it's a lower segment fibroid, you can't do a normal vaginal delivery. And if it's a cervical or broad ligament fibroid, you do a C-section. And post-op anticipate postpartum hemorrhage. Okay, that's about it. Is there anything other topics? No, most of it. That's all. And there's obesity, chooty ones, like an IUD in pregnancy. chorioamniotis, but those are the main ones.
I couldn't find anything in Deepal's book about amniotic fluid. No. But the Oxford Handbook cutoffs are amniotic fluid index is between 8 to 22. So if it's below 8, it is oligo. Above 22 is poly. So then
So,
probably, like he said, no, 5 is severe. Then the mean vertical pool cutoffs are, sorry, maximum vertical pool cutoffs are 2 and 8. So if it's below 2, it's oligo. Above 8, poly.
yes, complete amniotic fluid. Can you see the screen?
Not yet.
Okay. So it says 5 to 25 in this. It is NCBI. Most in Google most says 5 to 25, but then the Oxford says 8 to 22. Ne?
Yeah.
Yeah. So yeah, this says borderline is 5 to 8 and oligo is less than 5. Yeah. Most say 5 to 25, but I guess you can tell which guideline you follow. That is it. Any question?
It is also 5 to 25, like he said.
Ne?
Yeah.
Yeah. Yeah. It's annoying when different people have different nonsense. Unless stick to one.
Amniotic fluid in volume is 5 to 25. Mean vertical, maximum vertical pool is 2 and 8. So that is the same. Only thing is better to can stick to 5 to 25. No?
Okay, yeah, that's about it. Tomorrow I'll do gyne cases. Still writing the short one. Okay, good luck. Then bye. See you.
Thank you.